only effect here. These studies say that they were using animals and monkeys and rats they were using, and they making malocclusion to animal. They're putting premature contacts and wrong guidance surfaces. And when they examined those animals, they can see that occlusion disharmony causes TMJ displacement, maybe compression to the joint, maybe left and right problem of the mandible. And this is enhancing a stressful state to the body because the autonomous nervous system is dominated by occlusion and is making mandibular displacement, condylar displacement, so compression to the TMJ. And this produces significant increase of dopamine, stress hormone, of hypothalamic nucleus, stress hormones, and noradrenaline in frontal cortex. So all stress parameters were higher in animals when occlusion was malocclusion. Okay. A very nice orthodontic study. They were measuring the amount, like I showed before, measuring TMJ in patients, and they were inducing malocclusion in this patient, and they measured in the joint. And if there was retrusive condylar position more than 0.7, all those patients with induced malocclusion were increasing signs and symptoms of temporomandibular disorder: headaches, earaches, muscle sensitivity, and joint pain. Very old one. This is 1999 already. But still not proof enough. Study from Japan, two studies actually by Takeru Otsuka. He is a student of Professor Sato in Kanagawa Dental University. They were using kind of frontal jig, like you can see here, a splint with a frontal jig. If patient bite with force, mandible will back. Make compression, induce compression in healthy patient. And they were using functional MRI scan, brain scan, and measure area prefrontal cortex and amygdala, which is stress center of our brain. In control, no signal. With induced compression, strong signal, pain, and strong signal of hypothalamus, which means expression of adrenaline, increase of neurotransmitter area. So TMJ loading with retrusive vector produces significant state of human body from neurological point of view. So let's take a look at this patient. She's a biophysicist, neurophysiologist. She was doing all the rat experiments. Maybe somebody has read some of the stress literature, dental stress literature by Sato. She was the girl behind. She was, when we were working together, she was 5 years working with us, and then she suddenly said, I have a problem too. Can you examine me? No. So, and then we check, and we can find in her scissors bite. She was complaining about headaches. Let's check. She has headaches. She has reduced mouth opening, body posture problems. Every day taking naproxen 500 2 times against headache for 5 years. And no treatment. Then, after treatment, change occlusion. This is after treatment. Eliminate scissors bite, and then take brain scan of patient. Same. So this is before. ICP, clenching in ICP, with this bite here. Clenching in ICP, Brain is glowing. Pain, pain. Patient was provided with splint.
What ICP means?
ICP, intercuspal position.
It's like maximum.
Maximum intercuspal position. Yeah, MICP. Yeah, maximum intercuspation. So this one, this I was showing you. This is ICP before, and this is ICP afterwards. And strongly reduce, especially prefrontal area. See here, and especially reduce here and here amygdala, which means everybody know amygdala is brain center for primary emotion, like pain and stress and so forth. If patient with this occlusion, biting strongly, she has activation of stress center in her brain. If patient is biting with this occlusion, no activation of stress center, because occlusion is protecting TMJ. Very important. A follow-up study, same study setup, artificially induced TMJ displacement strongly influences neurological activity. It was possible to quantify how much compression in TMJ is okay and when does it start not to be okay. So there is the range, and this is what is very important. Starting with 0.7 millimeter retrusive position of condyle, stressful state in brain starts. So you have a very, very, very low tolerance of position of TMJ. Very low tolerance. But it's our task to make good occlusion to protect TMJ. Another little example, in this case, this patient, 40-year-old lady, very nice oral hygiene. No, really, very nice lady. Her history was, over the last 10 years, always complaining about some problem, toothache and whatever. Endodontic treatment, out. Endodontic treatment, surgery, out. Still pain. Why? And she's not crazy, not stupid patient, not psychological patient. No caries. I had all the x-rays of this patient, no caries, but toothache. Why? So, when looking at this patient for the first time, my clinical assumption was too low vertical dimension, and because of half class 2 occlusion, retrusive mandibular position with strong load to TMJ. And when we do further examination in this patient, we can see in the condylographic tracing clicking. And if we ask patient, always right joint clicking. 20 years. Clicking in this case means partial disc displacement. We know mandible is back. And this was the objective, to treat the patient. Again, we do the tracing to find out which is physiologic mandibular position in this patient. And we estimate that this is physiologic position. Anterior, down, and 0.5 millimeters to the left side. Okay? 0.7, sorry. So, our mandibular position we can measure is compromised, too far back and asymmetric. This is what we can directly use for therapeutic approach in this patient. Of course we did pre-treatment with splint in this case, but then we have to go to oral rehabilitation of the patient. And to make sure we can make wax try-in design, wax up, You can see the guidance surfaces here in blue. Already here we have the metal framework of the patient, and we can then see anterior position in the canine. You can see strong verticalization, about 4 millimeter verticalization of the patient. Yeah. And then after second try-in of the patient, we can confirm no more clicking in the joint, nice movement of mandible, nice mouth opening. We can go next try-in, we can make the ceramic surface in the lower, again use the wax in the upper, and then we can check canine position and everything. And then we go to manufacturing process in the lab. And then you can see the result in the mouth. At this time, we were using metal surface in the upper, more safety belt. Belt and what heißt Hosenträger? Safety parachute. Yeah. Lower one. This one, you might ask, what is this? The surgeon put one implant more. Put number 8. Didn't listen at this time, so you can subtract that. But it was there, so I had to use it. Yeah. You can see nice class 1 occlusion in the molar region, nice class 1 occlusion in the canine region, strong verticalization and coinciding midline. Please remember before. So change occlusion design, vertical dimension and mandibular position in this patient. Before and after, so you can compare. See, please. This is almost full class 2, and here canine, class 1 occlusion. So anterior position of mandible, functional anterior position of mandible. And you can compare the tracing now. Where this is before and this is after. Lower one is after. No nice movement here. Nice smooth movement here. And this is protrusion. You can see the clicking joint. No more clicking here. So we can confirm that condyle is repositioned in this patient by precise measurement. And patient was not having any symptoms. And also here we have a follow-up 15 years after reconstruction. I did this work 1999, 2000, this is from last year. So patient is anteriorly and transversely adapted by mandibular position using occlusion, creating new ICP. We're making new static occlusion, and we're using functional occlusion with canine dominance to unload the system. And still after 15 years, joint tracing looks very, very, very healthy. And patient is without any problems. Yeah, of course, I want to make a short break now before we go. If you have any questions, please.
The change of object is too large before and after treatment. static occlusion mandible is forward. How much?
You mean how much anterior position? Right TMJ 2 millimeters and left TMJ 3 millimeters. Here, you can see it. Starting position 3 millimeters here, anterior, and 2 millimeters here. So, over in the joint, 2 and 3 millimeters. In the edges, it's probably 1.5 to 2 inch.
You evaluated with condyle?
Yes. Condylography is so with condylography we can evaluate and we can program articulator to make this design.
And you check it with splint?
Yes, I check with splint here. Usually in patient with symptoms we should do pre-treatment, but we can try this position. Splint, you can test if patient is accepting new position, and you can make re-examination afterwards, and then you can go to final treatment.
I think that way, like he or she has like discrepancy between MIP and CR.
Yes, she has.
And
She
then
has.
you make it, you coincide.
Yes, I coincide.
Yeah.
I make new MIP, yeah, and new maximum intercuspation in different spatial position of mandible. Yeah. So it's new CR and new CO in this patient.
Did the patient take the orthodontic treatment or only
No orthodontic treatment because we proposed to patient orthodontic treatment, but she wanted to have new teeth, new crowns anyway, so it was not necessary to do. Today, after 15 years, I would say better to do orthodontic treatment before make nice arrangement of upper and lower arch. But this patient wanted 28 new teeth, so it was okay to do orthodontics only. Okay. Yes, let's have like a 10-minute break, 15-minute coffee break. Primary damage in the TMJ, what comes first? Usually, my opinion is malfunction of occlusion, premature contact, interference is first. Then hyperactivity of muscle function, and then secondary TMJ is damaged. TMJ is a very benign structure. It takes a long time for damage. So first there is loosening of the ligaments, then there is damage to the cartilage, and so on. And then symptoms and pain develops. Okay. I want to bring your attention to so-called delta Y. Delta Y is a transversal aspect of mandibular function, left and right, delta Y. So, deviation of Y-axis. One more explanation or one more reason why we have to measure TMJ movement, because clinically we cannot find any problem in delta Y. We cannot touch, we cannot feel by our hands if there is problem. Only in chondrographic tracing, this is y-axis, we can see deviation. Mandibular function, especially protrusion and speaking function, what I'm doing right now, is strongly symmetric function. Forward, only forward, both joints. If we have deviation, speaking like that, or speaking like that, makes constant disturbance in TMJ and making destruction of ligaments. We can see very early stage if we make joint tracing. You cannot assume clinical examination. Okay? There is very nice literature from Germany, a German colleague using measurement, and he has been defining the so-called functional physiological joint space. And he has been measuring x-axis, z-axis, and y-axis, so delta y. And he says that transverse direction, the tolerance of TMJ is not more than 0.8. So very little, less than 1 millimeter. Symptoms of TMD problem occur if there is constant transversal deviation in y-axis of TMJ. Nobody of us can feel 0.8 millimeters. We have to measure, especially if we want to change to better position. Much more important, I think, if we have compensated patient. Patient has no symptoms, has no problem, no complaint, and you want to make 28 crowns, or you want to make implant denture. If patient has hidden problem in TMJ and you don't see, maybe your treatment afterwards problem, because you didn't see compensation in this patient. This is why condylography, dynamic joint tracing, is very, very important diagnostic tool to see if patient has hidden pathology or not. My colleague, Silvia Cid from Portugal, she made condylography and MRI study, evaluated healthy patient and TMJ disc displacement patient. She made MRI and joint tracing. And she come up with every patient that has this displacement, delta Y, is above 0.75. 100%. So if you have transversal discrepancy in jaw movement, open close, and protrusion retrusion, you do have this displacement. And if you have patient with this displacement, very difficult treatment. If you put one more interference by your dental work, maybe patient afterwards with problems. This is very important. Much more important is this research, master thesis from our last course. This Italian guy, Carmignani. He was measuring delta Y and was correlating with skeletal classes. Very interesting is the outcome, because in skeletal class 1 have the highest incident of delta Y problems. So it means skeletal class 1 patient, which we think is good, are compensated already. So we have to be very careful. With 50% class 1 patients. Very, very important. So take a look at this patient. This is a neurological patient. She was working in our office. This is shopping list. This patient. Nobody wants to have any of these symptoms. She's a nurse. She's working with our maxillofacial surgeon, implant surgeon. At this time, I think, 32 years old. Pain, sometimes in the joint, but biggest problem is headache, strong headache on one side, and vertigo, dizziness she has. Getting up in the morning, she has to sit down again because she's shaking. She cannot go to work anymore because when she's concentrating, she will fall down. Because of that, every examination was done. She was getting to have depression, and she was having strong pharmaceuticals, antidepressive medication she was taking. And that was like many years ago. We were sitting in the waiting room, and I was talking to her why she doesn't come to work. She says, I cannot work. Impossible for me to work. And we were talking, and while we were talking, her joint was clicking. And I was asking, did you have dental examination? She said, no. I had orthodontic treatment when I was 12 years of age. I said, if every other examination could not help you, medical examination, why don't we check what is wrong maybe with your joint problem? She agreed. Also, during the last months before, she was losing her hearing. 45% reduced hearing on the right ear, and she was developing noise, tinnitus, on this side. This is a scheme when the ENT doctor measures the hearing capacity. Regular would be, should be able to hear 8,000 hertz all the time. This means 45% of reduction of hearing on the one ear. If we look into her mouth, doesn't look too bad, but we can see she had orthodontic treatment for premolar extractions, some restorations, some crossbite situation on the left side. But we can assume by the position of the front teeth, although looks like class 3, mandible is back. So assumption is retrusive position of whole mandible, which means load to TMJ. Okay? And if we take a closer look, please look at the condylographic tracing. On open close, she's fully locking. Only 2 millimeters movement. Protrusion on the left side, she's showing click. This is click phenomenon. We know this displacement is confirmed in this patient. And we know from research I showed before, if you have compression to TMJ, it is activation of pain centers in the brain. And this is, if you measure here, this is 0, yeah, and this one is maximum intercuspation. If this patient goes to maximum intercuspation, TMJ is compressed 1 millimeter on the right side. So strong load. And we learned before, more than 0.8 constantly is problem for brain function, for muscle function, and for stress. Okay? So, and in this patient, we take MRI tracing, of course, because we want to be sure. And you can see right TMJ and anterior disc displacement on the sagittal aspect. With reposition on opening, and we can see the transversal aspect, you have a medial, little bit medial, anterior disc displacement. So our assumption, joint damage, was correct in this case. Yeah? During that time, this brain study was conducted, and we asked patient to participate in this study. And this is amygdala, which is a brain center for emotions, primary emotion, pain, fear, and so forth. And this is prefrontal area. Prefrontal area is here, is when pain becomes, you become aware of your pain. This is activated. So if you're developing some pain. This is when patient is biting in maximum intercuspation. 30 seconds biting and immediately scanning the brain. Ooh, activity. This center, amygdala, means hypothalamus is activated and there will be adrenaline and dopamine shed into the blood. So immediately muscle will be reacting. Yeah? More. Already she's clenching and grinding, but when this center is activated, even more muscle activity. This is like a flight or fight situation. In this way. Only by compression of TMJ. So what is the consequence? The consequence is we need to change occlusion in this patient. Okay? In this case, don't waste any time with splint. She needs orthodontic reconstruction anyway, and she has been suffering with her problems for 3 years or something. So no waste of time. Immediately go to irreversible treatment in this patient. A little bit more than 1 year. Change a little bit occlusion. Change a little bit arrangement. Make sure no more retrusive position in this patient. No more false bite, no more interference. You can see nice raising of the bite with uprighting of molars and thereby unloading TMJ. Excuse me? You can ask questions. And if you take a look at tracing afterwards, no more clicking. Open close was only 2 millimeters before, now nice opening. So unlock TMJ by changing occlusion. And very nice and smooth movement, which means very harmonious muscle function in this patient. And then sent to ENT doctor to make re-examination. Hearing come back. Her hearing comes back. Ear noise gone. No more ear noise. And MRI. This is bad quality, I'm sorry, but you can see disc is in between. So this is reposition treatment of TMJ by orthodontic treatment, by changing occlusion. Unload. And brain scan afterwards. Now, new ICP, new ICP, patient biting afterwards, no activation of brain centers. So now occlusion is not giving stress to TMJ and not giving stress to patient and complaints. So she doesn't need any medication anymore. No painkillers and no depressive medication. ENT symptoms gone and stress-associated brain areas could be significantly pacified. This is an MRI finding. Sorry. You must believe me now. But this is an MRI afterwards. Inside. The radiologic diagnosis is regular physiologic position, both TMJ repositioned sagittally, so anterior, and transversal. It's not disc back, it's condyle forward. The whole mandible is coming a little bit forward. And you can see the reposition of the disc here as well. Only by changing muscle function controlled by occlusion. Okay. Anybody think occlusion is important? Okay. Let me check. Have we done this before? So I believe occlusion is important. Anybody of different opinion? Like in church when marriage, if you don't believe occlusion is important, you have to say it now so I can convince you, otherwise be quiet forever. Okay, now this is a kind of brief overview, scientific aspect, some example. Now I want to take you back to the concept and the single steps of the strategy. How do we do it in everyday life? Here you see condylography and so forth. I will be using this patient case from A to Z and show every little step, and then we will ask the patient to come up and we will demonstrate the clinical examination and the condylography. Okay? So, any questions towards the significance and importance of occlusion for masticatory organ and medical function? No question? Not really. If I was so convincing, I can go home now.
저기 통역 좀. 네, 질문하세요. 그 클래스 1에서도 좀 굉장히 리스키하다, TMD에서 리스키하다고 하셨는데, 실제로는 이제 클래스 2 스켈레탈에서 상당히 많이 TMD 증상을 호소하잖아요.
클래스 2에서 많이 증상 호소한다고요?
네, 근데 이제 스켈레탈 클래스 1에서도 많은 위험성을 내포하고 있다는 거에 대해서 조금 더 부가적인 설명을 해주실 수 있나요?
자매들은 아니라 클래스 1 Problem, wenn der 50% Problem mehr. Und dann er wollte normalerweise Class 2 ist das, wir haben mehrere Probleme. Aber
okay, yeah, I understand. Okay, the outcome of this study was, you are right, usually in class 2 patients, skeletal and dental class 2, we have higher coincidence of symptoms. This study is showing that class 1 patients have a high percentage of signs. They don't know they are compensated patients. It's, we call like hidden pathology. They have like compensation mechanisms. They don't have any pain. They don't have any problems. But these are the dangerous patients for our office. Patients that don't come and say, I have TMJ pain. They just say, I want crown, I want implant. And you do treatment and maybe patient collapse afterwards.
하나 더 있는데 저기 지금 전에 치료했던 케이스에서 로이어 케이스랑 이제 방금 전에 케이스에서도 사실적으로 보면은 교정 후 이러한 그 TMD가 발생된 것으로 저희 추정을 할 수 있는지, 교정으로 인해서 예를 들면은
발치 교정.
발치를 함으로써
Zwei Fälle war, die Patientin hat bevor eine Orthopädie-Behandlung gemacht und danach Problem.
Ja, genau.
Vielleicht das war eine, das könnte man sagen.
Ja. Very, very many times our profession is responsible for creating TMD problems. Very many times orthodontists they ignore skeletal and functional principle, maybe premolar extraction. It's absolutely wrong to make premolar extraction in this case. Then make non-functional occlusion. And then secondary is load to the TMJ and all those medical problems develop in this patient. We have to be very careful. This one guy I was citing before, he says 80% of TMD patients, our fault of dentist, because not using the brain in dental treatment. We have to use our brain. Hey, let me tell you a joke. This is very good. Please imagine the year 2094. Medicine and science has advanced. We can transplant brains. And we can recover old brains. And like new Apple stores, we have brain bank. You can go to shop and you can, oh, thank you very much. You can select new brain for yourself. And this guy, very wealthy guy, he already fly to the moon, he has so much money, he has brain tumor, only 6 months to live, and he wants to buy a new brain to live on. And he goes to the brain bank and he looks, there's all those famous brains. One is Steve Jobs, 25 million brain of Steve Jobs. Another brain, Albert Einstein. You know Albert Einstein, very famous Nobel Prize winner, 1923 or something. Relativity theory, 40 million. Then there is brain of George Bush, 10 million. And many, many other, like Heisenberg, all those famous people, you can buy them there up to 200 million. And a little bit in the corner, very nicely enlightened, there is a brain, 500 million, no name. And the guy says, wow, who's this? This is an orthodontist. And he says, why is it so expensive? It has never been used. Okay. This is why I asked if there is any orthodontist.
아까 말씀하실 때 제가 받아들이기는 미드라인 데비에이션 클래스 1에서 굉장히 중요하다고 보는데 1mm 이하의 데비에이션도 상당히 큰 영향을 미친다고 이해를 했는데요. 이제 그걸 조금 확대해서 봤을 때 이제 뭐 그거는 굉장히 중요한데, 그러니까 이제 미드라인 데비에이션뿐만 아니라 AP적으로 데비에이션이나 아니면 그 좌우의 편차, 그러니까 그 버티컬 디멘션의 섬세한 차이도 역시 그만큼 더 중요한지, 아까는 그걸 미드라인의 데비에이션을 굉장히 강조해서 말씀하셨는데 그게 지금
Wrong question.
That resulted in a bit midline deviation is wichtig für die meinte slides. Die vertical measures are anti-posterior deviation is not more.
Yeah, okay. The midline, a midline discrepancy is indicator. Is you're right. Vertical dimension and sagittal aspect is equally important. The midline deviation or midline discrepancy could indicate some transversal deviation of the contact. Both is important. So the dental midline is only indicator. It's not diagnosis. You have to be sort of very careful with this definition. Okay.
그러니까 질문 하나 더 있는데요. 어떤 경우에는 컴펜세이션이 되고 어떤 사람인 경우에 어떤 사람인 경우에는 컴펜세이션이 안 되기 때문에 심통이 나타나는 거잖아요. 그런 부분에 대한 근본적인 그런 차이는 어디서 오는 거일까? 어떤 사람은 컴펜세이션이 되잖아요. 어떤 사람은 심통이 나타나요. 그러니까 그게 어떤
Telling a joke as well.
Er meinte, jemand hat ein Symptom und andere Leute hat kompensiert das.
Ja.
Und wie kann das man sagen, was war Grund von dem, wenn man akzeptiert und wenn man nicht akzeptiert? Die Symptome.
Das Symptom.
Ja. 질문을 조금만 더 구체적으로 해주시면.
어떤 사람은 그 심텀이 히든 데서 그 숨어져 있잖아요. 그러니까 그거를 어느 정도 이렇게 톨러런스가 있는 사람이 있을 거고 톨러런스가 없는 사람이 있잖아요. 그거는 그 사람이 선천적으로 타고나는 건지 아니면 어떤 우리가 흔히 얘기하는 어떤 사람의
I think that gets the question.
the
When to accept the symptom and the sign? Yeah, I understand. Yeah, it's not, in everyday dental office, this is a difficult question, but very important question. Actually, it's what I'm supposed to show right now. We're using these forms here. First examination. All these questions are relating to symptoms of the patient, and examination is signs of the patient. We can correlate. If we are not sure if patient is TMD patient or if it's acceptable, we have to wait maybe 6 months and then again do examination. And then we can compare. If problem get worse, is the patient. If not, okay. If it's patient and the symptoms getting worse and signs are getting worse, we have to treat. Conclusion. We have to treat. If no change or getting better by itself, no problem. Yeah? And there is international objective criteria, RDC TMD, like Rocking 1992. There is research diagnostic criteria for temporomandibular disorder. This is a famous publication. It's very similar to our examination, like a clinical functional analysis, palpating muscles. This is, you have it in English. Yeah? It's shoulder muscles, masticatory muscles, and joint palpation. This classification says, and we're doing the same, if 3 or more muscles are painful, and if 2 or more spots of the TMJ are sensitive to palpation, this is TMD patient. Is that answering your question? No. I can see by your face. No. Wrong explanation.
Later.
Later?
Yeah.
Okay. So, okay, this was a good introduction. Thank you. Medical analysis. We're asking the patient for his main concern. Dental analysis, dental history. Psychological evaluation of the patient. And then 14 muscles and 8 spots of TMJ. Lateral capsule, opening the capsule, ritual joint space, and temporomandibular ligament. Okay? Professor Slavicek likes to call this form is the dental striptease of the patient. Please translate dental striptease into Korean. Everybody needs to understand. Striptease. Striptease. Peep show.
지금 슬라비책 교수님이 평소에 이쪽에 지금 검사하시는
저쪽을 보면서 그 스트릿 쇼 하는 사람의 그걸 표현한다고 합니다. 왜냐하면 자세하게 모든 것을 다 드러내는 거기 때문에 스트릿 쇼 한다고 합니다.
Because it tells so much about the patient. In the first appointment, if you ask the patient, everybody can have that. You can distribute that. No? Okay. Thank you. Okay. Yeah, everybody can take a look at that. If you're asking the patient the questions, do you have problems when you chew? Do you have problems talking? And so forth. You make a dialogue with the patient and you find out which function is compromising the patient. We are referring to postural aspects, body posture. We're asking about the structures of the teeth if they are sensitive. So, after you have this interview with the patient, takes maybe 10 to 15 minutes usually. You know so many things about the patient, you can decide treatment or not. Okay? So, let's go through the diagnosing system and the treatment decisions along this patient. Yeah? We can copy if somebody wants to have it. Very sad patient, you can see. So, and what we do is to find out the subjective findings of the patient. So, the symptoms. Here is the so-called occlusal index. Occlusal index is a ratio. The patient is defining the strength of his complaint. If you ask him, do you have problems when you chew? He says yes. It's a yes. And then you ask the patient, how severe is it? Do you have pain when you chew? Can you chew hard food? And so forth. So you get a good idea of the patient, how strong his symptom is, to define treatment or no treatment. Scale. 1, 2, 3.
1, 2, 3.
One is patient is aware of a symptom. Clicking is existing. Is 1. Painful clicking sometimes when chewing is 2, because it's disturbing the patient. Always pain would be 3. Unacceptable problem. Yeah. So mild, moderate, severe. 1, 2, 3. And then you have so-called occlusal index ratio afterwards. Can be 1, can be between 1 and 2, and can be between 2 and 3. 1, usually not severe problem. Usually not severe problem. Between 1 and 2, most of the time, occlusion problem, health problem, treatment. Above 2, very dangerous patient, maybe supranasal problem. Very many times. For above 2, you need 3, 3, 3, 3 everywhere. These are those crazy patients you don't want in your office saying, pain everywhere, and every time pain. You have to be very careful with those patients. But again, this is the dental striptease, the peep show. You know a lot of things about the patient when doing this form. You get to know the patient. Yeah. You strip your patient, or the patient strips for you. And he doesn't even know it. Not aware. So you become a psychologist. Yeah, and then there is questions. Did you have accidents? Face, like car accident or something? Because we have to look for trauma in the past as well, if we have TMD problems. Did you have oral intubation, narcosis, surgery with oral intubation? Very dangerous for TMJ sometimes. Okay? Then, did you have dental treatment, orthodontics, orthodontics, selective grinding? Did you have splint therapy? Very important. Did the patient have treatment before? Are you clenching and grinding your teeth? And very important question to find out the crazy patient. Do you think treatment is necessary? We ask the patient. Look at the patient and say, do you think treatment is necessary? Do you want me to treat you? It's an important question. Because many times you can see all those patients, very extensive and long treatment. Maybe orthodontics, maybe many crowns, very extensive treatment. Patient needs to have good compliance. You have to ask him if he wants treatment. If he thinks it is necessary, if patient don't have compliance, it's very difficult to treat. He will be always impatient. So this is the problem list of the patient. You can read that. This is not... you can have the file later. You don't have to make pictures. You can, of course, but I will give PowerPoint to you. Yeah, it's easier. Better quality than photo maybe. Yeah. Actually, you can read that later if you want all those symptoms. This is full clinical examination of the patient. On our form, on this one, or on this one, we write down all of this. The patient comes. Everything. Yeah? Full clinical examination. Perio status, endodontic status, and so forth. Yeah. We have to have very good communication. Hachi, bless you. So, enter all pictures. Get a good first impression of the patient. She has a genesis of 4 premolars. Dental treatment, only some partial crown and some filling over there. But gap here, gap here, gap here, gap there. All tooth number 5 missing by birth. Congenitally missing. You can see the flaring of the lower front teeth. Gap here, gap there. And upper premolars missing. Somebody tried to treat her. 2 orthodontists before tried to treat her. First one want to open space. Second one want to close space. Patient could not understand and stopped treatment. This is result. Yeah. So, and if we look to our objective examination now, patient 1+ is sensitive muscle, double plus painful muscle. But almost all of her muscles, some objective signs. Okay? There is research work by Cecily defining the calibration. They're using a weight 150 to 200 grams per patient to the muscle. Like this. Not more. Does that hurt? No. So you can calibrate the patient. This makes it objective. And then if you go here, does that hurt? No. Good. No. No pain. If it was pain, it is an objective sign of muscle hyperactivity. This is the way you can do it. Yeah. Scientifically, very valid. And on the left side, all findings in joint capsule, same. You can calibrate. Give me your hand, please. No. Okay. This is the force. This is healthy joint. This is my force. I show to patient. And then you go to TMJ, you use same force. Open a little bit. Stop. No, only a little bit. Only. Stop. Painful. Open. Close. Painful. Little. Same force here. This joint, 25 times more pain fibers than TMJ. So, no pain here, little here, something wrong maybe. But maybe Saturday, drink wine or beer, this night clench, today little bit sensitive joint. Maybe no problem. Do same examination in 6 weeks. If still problem here, sensitive, maybe occlusion problem, causing some symptom in joint. This is periosteum is how do you say, irritated. Periosteum is irritated. This is finding, objective finding. This way, maybe this is a little bit answering your question. This is how we find out patient, risk patient, or not risk patient. If nothing here, everything blank, no findings, you can do everything with patient. 28 cadmium, zircon dioxide crown, no problem. Yeah, no problem. But if you have these findings in patient, you have to be very careful. Because compensated patient, and compensated patient is always at risk. If we make one little interference too much, and patient clenching and grinding, maybe afterwards, big problem. And if you have to redo big dental work after short time, yeah. Who pays? Who pays the lawyer? We do a so-called neurological screening. This is checking the symmetry of mimic muscles, checking the symmetry of eyeball movement, checking the symmetry of throat muscles. Why do we do that? Have any idea why? Which is the big nerve for the face? Trigeminal nerve, cranial nerve number 5, is responsible for every sensation in the face and the head and the shoulders. And shoulders has close connection. One branch is going to this part of the shoulder and has close connection to C1 and C2, cervical spine. Fibers going together for the muscles and the skin of the shoulders. So close connection. And for everything I'm doing today, speaking, chewing, and clenching, the motoric part, also trigeminal nerve. All these other nerves here, all these other 12 cranial nerves, same position in our medulla, very close to each other. If you have irritation of the one nerve, can make symptom or sign somewhere else because of constant irritation. This is why we have to check that for differential diagnosis. Maybe patient has some other problem and pain in the face. Sometimes patient has shoulder problem. I showed before the girl with the cervical spine with the postural problems. Sometimes make TMD symptom, but not occlusion is the cause. We also have to be careful here. Make decision for other medical examination. Sometimes it's necessary. So in this case, patient, no problem. And then, very important, we will demonstrate later. Maybe you remember my one slide. Yeah, this is what it is. My one slide when I said, first we're looking for facts. The first two forms, subjective and muscle palpation. We're looking for facts. What? Only what? And then we make in our brain a correlation between that. But then the next step is look at occlusion. Can occlusion be a factor? Okay, what do we want? We want to see nice ICP, maximum intercuspation. Yeah, we can check it easy with wax. But we can also make patient move and we can check for interference. Or we can check if canine guidance. We can check if too strong front tooth contact. This is our first impression in the first appointment. Can occlusion be at risk for this patient? And then we can again correlate this finding, which muscle is sensitive. If some patient has some balanced contact here, which muscle would be sensitive? Balanced contact here, so you go this way, Which muscle is sensitive? Yeah, maybe it makes a delta Y, it's a interference. Yeah, maybe it's interference. And then this muscle would be sensitive. Lateral pterygoid muscle would be sensitive because if there is interference, system will try to avoid. Patients don't like to have interference. Muscles will try not to have interference. And this is where muscles will be sensitive. This is how we can find out. Is occlusion risk factor? In this case, because patient was reporting headaches and earaches and so forth, we use consiliary examination. We do have these forms as a writable PDF. So if you want to have these, I can distribute later. I can send. This is for orthopedists. This is same systematic structured examination. If I have, like, let me go back just a second. I go back here. If these muscles, this is shoulder neck, this is atlanto-occipital region, this is sternocleidomastoid muscle, and omohyoid muscle is going to the shoulder. If these muscles are sensitive, I know patient has postural problem. But I need to check, is occlusion factor, causative factor, or does patient have orthopedic problem? Maybe one leg is too short, maybe some foot is not okay, some problem in the hip, some problem with the cervical spine. Not everything is occlusion, but I have to check. But I cannot do, I'm dentist. I have to send to specialist. And we use this form, these forms. We have for neurology, we have for ENT, we have for physiotherapy and so forth. Yeah? I tell patient, take this, see specialist please, and bring back form. And I'm asking the questions. Yeah. This way I find out priority number 1 is occlusion or not. Okay? If primary problem is body posture, first treatment of body posture, then treatment of occlusion. Otherwise, dangerous. Please remember the values I was talking about between 0.7 and 1 millimeter tolerance in the joint. Body posture, much higher tolerance. So if they change something, 1 centimeter or something, but effect here can be very strong. So changing body posture means changing head posture, which means changing mandibular posture. So if we have primary orthopedic problem, we need to treat first. Yeah? Okay, so there were no findings in this patient. If there were no findings, I have to assume with seeing this, I can see interferences. I have many findings in the muscles, I have many findings in the joint, and I have a positive interview with the patient, with a one